the video look okay?
The feature requires Adobe Flash Player to be installed. Oh, there I am. Right. Well, this is amazing. No? You are live, he says. I am live. This is amazing. I'm talking to supposedly several hundred of you out there in the world. I don't see any of you, so it's a very weird experience, I have to say. Well, welcome everyone to this ClickCast. We're very excited about it. This is our first attempt at communicating to you all in this way, and I hope you're finding that it's a very easy venue and that you can hear me and see me, and we will get to all of your questions. My name is Marc Levitt. I'm a pediatric surgeon specializing in colorectal surgery. We are in a unique place in Cincinnati. This is the world's only pediatric colorectal center that has a comprehensive and multidisciplinary team to take care of children with problems related to the colon and rectum. So you probably all know that in every adult hospital there's a colorectal department, but this is the only one that really has a totally comprehensive system just for children. We have a number of partners actually around the world in a number of countries that are working hard to develop similar programs, and we are working hard with them to help them and to train their doctors and nurses. Well, the biggest problem that many of our children face, besides some of their surgical needs, is the ability to be perfectly clean for stool. And the concentration of tonight's hour is to discuss some of those issues and convey to you our treatment plan for children with these sorts of problems. And to use our generic term, it is the Bowel Management Program. And our specific focus tonight, although this applies to many, many children, is to concentrate on patients with spinal problems, most notably Spina Bifida, which is a particularly common problem in children and can affect both the bowel and the bladder. We have done well, I think, in connecting to patients with surgical problems related to the colon, namely conditions like anorectal malformations, problems with missing anuses that need to be reconstructed, and a condition called Hirschsprung's disease, because everyone knows that those are surgical problems. But patients with spina bifida, people don't necessarily have good solutions for their colon. And yet there's a lot of suffering that happens with those types of children. And we wanted to connect to that group of patients and explain that some of the strategies that we've utilized for the surgical patients in getting them clean have actually worked extremely well with patients who have spinal problems and therefore have problems related to their colon. So that's what tonight is all about. You are going to be feeding questions, typed questions, and then I'm going to see those questions and answer them. And we're basically going to try to have as natural a conversation as possible. I wish I could see you in front of you, be right in front of you in person. But the only way we're going to reach about 50 different countries and about 200 or so of you is to do it this way. So we'll see how that works. So I wonder, are there any questions yet? So far, there are a few coming out. Well, let me just explain to you why it is that we find ourselves in Cincinnati. We needed to create a center that was multidisciplinary and had very detailed nursing infrastructure, which is absolutely key to the bowel control issues. And Cincinnati Children's approached Dr. Pena, my partner, and myself about 6 years ago now to create this center in Cincinnati, and we moved our families and we plopped ourselves down in the Midwest. And we've been growing ever since. We now have 6 surgeons concentrating on colorectal problems and 9 nurses that we work with on a regular basis. So the center is growing, and there's obviously a great need out there. Let's see, there's a question here. So there's a very good question. The question is that I'm not sure where this person is from. If possible, when you post your question, sort of say a handle, a name. You don't have to reveal your identity, but so that I can reply and say who was asking and where you are from, because I think it's very interesting, at least for me, to know where all these questions are coming from. But the question I'm reading here is that is whether or not it's possible to effectively manage constipation if tethered cord is the underlying cause, or would it be impossible until the spine was detethered? So that's a very good question. And the answer is that from a colon point of view, the tethered cord does not have an enormous impact. Tethered cord is a spinal condition whereby the very bottom of the spine is attached to the bone of the sacrum bone, the tailbone, the thing that when you fall on it hurts. That piece of the bone can be connected to the spine, and as the child grows, the spine is sort of stuck, and then it is tethered and can be stretched. And that can cause pain in the legs, and it can cause symptoms related to the bowel and the bladder, mostly the bladder. Sometimes it affects the bladder, but mostly affects the, sometimes it affects the colon, but mostly affects the bladder. And the answer is, without a doubt, we can treat that. It's important to know that it exists. It doesn't really impact constipation so much, but it impacts a child's ability to be continent. And what I mean by that is that patients may or may not have the ability to feel that they have stool there and know that it's there and can hold on to the stool and make it to a bathroom. And for patients who have no ability to do that, they are going to have an accident. However, we can fake out that system mechanically and do what's called a bowel management program, whereby we empty the colon with an enema, and then for the next 24 hours the colon remains completely clean. And that's a patient who is completely clean and in normal underwear, albeit artificially. So the next question I see here is, at what age can you begin enemas? And that the person also notes that they're currently using Miralax and they hate it. Well, join the club. I hate Miralax too, and I don't use Miralax. Miralax, as well as many other medicines, are what I would consider stool softeners. Stool softeners are not what these children need. These children, in fact, are worse with stool softeners, and it's probably why you say you hate it. Because what it does is it makes the stool soft and mushy, and then it leaks out. If you're going with an enema program, you actually want the colon completely quiet between enemas. So the last thing you'd want to do is give a stool softener. You want an effective enema that cleans the colon, and then that colon remains quiet until the next enema comes along and cleans the colon again. And then, of course, between enemas, you have a perfectly clean child. As far as what age you would start enemas, basically whenever you want the child out of diapers. So I have 3 kids, somewhere between age 3 and 4. And in between age 0 and age 3, there's nothing wrong with having the child poop in the diaper. But when you want the child out of diapers and they don't have the capacity to have bowel control, then the way to go is a mechanical system with enemas. And then they are perfectly clean. And they can be clean just at the age of all other kids being clean. All of their buddies are at that age, they're out of diapers or in normal underwear. So too should a child without the capacity for bowel control. The next question is about a low anal tone, and therefore leading to leakage. And that is a common problem, particularly with patients with spinal problems. There's nothing wrong with the anus or the colon, but because of the spinal issue, and those include things like tethered cord or a myelomeningocele or syringomyelia. There are a lot of fancy medical terms about neurologic issues. This includes patients who have had spinal injuries. A person in a wheelchair, because they have a spinal injury, may have low anal tone. But the truth is we don't care, because with the right colon clean out, the anal tone is not relevant. Because if you clean the colon and slow down the stool so it is firm enough so it doesn't leak out, even with a low anal tone, anal canal, that child can remain clean until the next enema comes along, cleans the day's stool out, and then the child remains clean for the next 24 hours. So it's a very good question. It's very typical of patients with spinal problems, but it's one that is easily overcome by this enema regimen. So let me explain what I mean by having the capacity to have voluntary bowel movements. I think people get very confused about this point. And in fact, many doctors out there, I think, never ask the first key question, which is, does the child have the ability to have voluntary bowel movements? Do they have the capacity to have voluntary bowel movements? Now, the reality is that most children do have the capacity. They may not figure it out right away at the age of 3. They may figure it out later in life. Or they may have no ability to have bowel control because of whatever issues are going on. Namely, the spine is not affecting the colon correctly, and therefore the colon won't work, or certain circumstances of patients born with anal canal malformations that need to be reconstructed, and a certain group of patients with Hirschsprung's disease. The vast majority of patients luckily have the capacity to have bowel control. Then why might they be soiling? Well, the first question is, do they have the possibility of gaining bowel control or not? And that's the first question we ask. And patients with spinal anomalies, often the answer is, at first they do not have the capacity to have bowel control and therefore need a mechanical regimen to empty their colon, namely the daily enema. Later in life, maybe at age 4 or 5 or 6, when they've gained maturity, when they're more actively involved and more interested in potty training strategies, we will try to see if that child can realize their potential for bowel control. And often, because they've had a period of time of being 100% clean, although in an artificial way with enemas, that confidence that they have, the fact that they are in normal underwear, means they never want to go back to diapers, and they are much more active participants in your attempts to potty train them. Now, of course, there are patients who, no matter how hard they try or how motivated they are, they simply do not have the capacity to have bowel control. And I think it's very important for the surgeon or the doctor to determine that up front, to avoid a lot of stress amongst the family of why this child continues to soil. And that's why, in those circumstances, I think employing an enema program is the way to go, because that patient will then get clean. And then we can determine that there's a child out there who, for whatever reason, spinal problem or a problem with the colon, things that cannot be made to gain bowel control, that's a child that needs enemas to remain clean. They can absolutely remain clean with enemas. And then the discussion that comes up is whether or not to take the enema and not give it through the anus, but rather give it through a more comfortable route. And the way to do that is to connect the appendix to the abdominal wall. And we like to do that in the belly button, so it's hidden. And then through that opening, we pass a tube, and that is where the enema can be given once a day. It's a really neat operation that was developed by a Professor Malone in the United Kingdom. He's a urologist who figured out this great idea of connecting the appendix to the abdominal wall. And we took that idea and ran with it. We've actually done more Malones than Dr. Malone at this point because we have so many patients who would benefit from that procedure. So we're waiting for more questions, and you're welcome to send them our way. So getting let's see. Oh, here we go. All right, let's see. What kind of balance do you need with fiber? Any certain kinds of fiber in particular that you recommend? Well, this is a very good question. So this is from Baby First 11. The challenge here is to get the right consistency of stool, because of course 6 loose stools a day would be difficult for any person to handle and maintain perfect continence. So the ideal is to have a formed stool. If you're doing enemas, having a formed stool that gets washed out by the enema is ideal. If you're trying potty training, 1 or 2 formed stools a day is vital. 6 stools that are loose, forget it. You'll never successfully potty train such a child. So one of the strategies that we use is to manipulate the consistency of the stool. And one of the great ways to do that is with diet and fiber. So there are a whole host of foods that are constipating, and there are groups of foods that are laxative provoking. And there are nice lists of these foods available on our website. I can go over a couple of those with you. Obviously, bananas, rice, applesauce are binding. Things like sugar drinks, oily or fatty foods make you go and can be detrimental if you want to not have that happen. And fiber is key. There are really 2 main types of fiber. One is water soluble and one is water insoluble. And you need to choose the right one for the desired effect. So water soluble fiber does what it says. It dissolves in water and it provides some bulk to the stool. Water insoluble fiber runs through you and provides some looseness to the stool. So it depends on what strategy you're employing for the consistency of the stool, which type of fiber you would use. So for example, benefiber, as an example in the question, is one of those that can go either way. Different people have different reactions to benefiber. So we use a lot of pectin. Pectin, you probably know from the supermarket, is what's used to make Jell-O. So we tell the kids that we're making their stool into Jell-O, which they get excited about. And the other thing we use is something called Citracel, which is a nice water-soluble fiber, and it provides some bulk. So Supermom, and that there are a lot of Supermoms out there, so I'm sure 100 of you think that I'm talking to you, but this particular handle is called Supermom. It's talking about her daughter who has a cecostomy and is 11 years old. We do her program every night. It takes 90 minutes. We use 500 mLs of Go Lightly with 20 mLs of Bisacodyl Fleet. Is there anything I can do to make it go faster? Well, it's a very good question. So what Supermom is describing is that they are cleaning her daughter's colon from top down. Similar to the idea that I mentioned about the Malone with the appendix, but in this case she's using what's called a cecostomy, which is a part of the colon connected to the abdomen with a tube. I don't like those kind of things because the tube itself can be irritating. The kids often don't like to go swimming because they are embarrassed by the tube. I like a Malone because it's hidden in the fold of the belly button. But what the question here is, how do we make this enema regimen more efficient? I have to tell you, I don't like the Go Lightly as a daily flush because it's very dehydrating. And I also don't use Bisacodyl Fleet. We would use saline, which is salt water, basically, and there's medical saline that you can get in a prescription, and then there's salt water that you can make up with a very prescribed formula. Saline, and 500 cc's is a good choice, but we determine our amount by the size of the colon. And the size of the colon we view by a contrast study of the colon, and based on that view of the colon, we guess at the enema volume that would be required to clean that colon. Then we will add things to that saline. Usually our first additive is something called glycerin. To make the enema a little bit more strong, we might add then Castile soap, and to make it stronger still, we would add phosphate. And there are patients out there that are on saline plus glycerin plus soap plus phosphate. And the rare patient that has an enormous enema, or one that takes an awfully long time, and 90 minutes is a long time, we sometimes will remove some of the colon to make the enema more efficient. And that's a surgery called a sigmoid resection. And not uncommonly, we will combine that with the Malone. And we do the Malone and the sigmoid resection together. But very important, it's to know the enema that works for that colon first. So our routine would be to guess at an enema volume, and then over the course of about 5 days, with an abdominal x-ray each day, we determine, did our enema work? Did it clean the colon? How does it look like on x-ray? Does the x-ray show that last night's enema was successful? If not, we might add something to the enema. So, and that's the game we play to figure out the perfect enema for that colon. And it usually takes us about 4 or 5 days to do that. I have a question here. What are my thoughts on probiotics? There's nothing wrong with probiotics. I'm not sure if they really help or hurt. What the concept is to improve the bacteria, the normal healthy bacteria in the colon. And I think a good set of bacteria in the colon that is routine and counted on and there every day makes for a regular colon that does its duty every single day in a routine. Of course, everyone knows that if you get ill when you travel, if you have a bad bacteria, that bacteria messes up the population of bacteria, and that's why you develop diarrhea. So nothing wrong with probiotics. I don't think it's that relevant, frankly, in many of the patients who require a mechanical system to empty the colon. It's probably more appropriate for patients who you're trying to regulate the colon, getting the right consistency of the colon so that the colon empties on a regular basis, and the child knows when they feel a certain fullness that they can then go on to the potty and stool. It's probably more relevant in that patient group. So another question here is mum to 3. My wife is also mum to 3. So, but I like the mum, M-U-M. I bet you're from the United Kingdom, Australia, or New Zealand. Tell me if I'm right. Would you consider a total colectomy for constipation? So the answer to that is only in a patient who has a miserable colon to clean. And it's exceedingly rare that patients cannot get better with the right enema regimen or the right medicine regimen and do not need surgery. And it's sort of funny. Here you are talking to a surgeon about not needing surgery. And I can tell you we learned a lot about the medical treatment of colons because many of our surgical patients, those ones I was telling you about, those with imperforate anus and Hirschsprung's disease, had very nice surgeries by us and then had trouble often with things like constipation or incontinence. And we felt obligated to make sure the child was clean. So we learned a lot of medical strategies to get people clean. So largely, there are patients out there that need medical treatment and they don't need any surgery. But the question is about a total colectomy, exceedingly rare. Much less rare would be removing a segment of the colon, not the whole colon, to make the enema routine a little easier, or to make the amount of medicine, the laxative that the child requires, a little bit less. So we would normally do a sigmoid resection, which is about 25% of the colon down on the left side towards the end, not the entire colon. That's a pretty radical treatment that we have employed only a very handful of times in very, very serious circumstances. So I see another question coming up. I think it's a good question. I think people move to surgery probably a little bit too quickly because they feel frustrated that they didn't get the enema program to work. And I don't think the enema program doesn't work because it's not a good idea. I think it's because the right regimen was not arrived at. So here's a question from someone who says that they want their son to go to our hospital and see if you can help him, but the insurance won't cover it. What can I do? I had a suspicion that we would get some of these questions. I can tell you that we have taken care of patients from 80 countries and from all 50 states. And every single family has the same financial challenge. And frankly, one of my biggest frustrations is that the bureaucracy of medicine and the finances of medicine stand between me and the patient. Because if it was up to me, I would say, come on down from Wisconsin tomorrow. I'd be happy to see you. Unfortunately, what lays between us is a mound of bureaucracy. But the power of particularly mothers, no disrespect to fathers because I am one of them, but the power of mothers to fight on behalf of their children has been an amazing thing for me to experience. And I can tell you, if you are successful in making the argument that we can help this situation and someone under your insurance umbrella cannot, most insurance companies eventually agree because they really would like the problem solved. Excuse me. And we have some really talented folks in our office. A large section of our office is working the bureaucracy angle because, as you can imagine, the amount of bureaucracy that is involved in patients coming from all over the world and from all over the United States with 50 different insurance programs just for Medicaid, let alone all of the private insurers. There are an astronomical number of options and choices, and our billing team is quite expert. So my recommendation is to help us help you fight that fight, but you will be a very important advocate in that, and we would really like to help you, and that's our goal, is to try to figure out how we can help you. So I thought I saw another question coming up, but here we go. This is a good question. What is the youngest age that the ACE or MACE can be done? And just to fill all of you in, these are all the same terms. ACE, MACE, Malone, appendicostomy, those are all the same. Cecostomy is a little different because it means the cecum, which is a part of the colon, not the appendix, which is connected to the colon, is attached to the abdominal wall. Cecostomy to me means that there's going to be a plastic tube to get access to that colon. I'm not sure if you mean ACE or MACE by the specific procedure, and I can answer more details about that, but basically we're talking about getting the enema program easier, not through the anus, because it's not comfortable. Now for a little baby or a 2-year-old or a 3-year-old, it's not a huge deal, but as the child gets a little bit older, it becomes an enormous deal. The nice thing about the Malone or the ACE or the MACE, whichever term you'd like to use, is it, first of all, makes the enema program a lot easier, and it allows the patient to do it themselves. It's a lot easier to put a tube in your belly button than it is to put an enema in your anus. So what is the youngest age? Well, I would tell you that we really wouldn't start an enema program to get a child clean until the age of potty training, because there's no point in doing that. Child's perfectly happy in diapers until the age of 3, 3.5, something like that. Frankly, a lot of that depends on the family and what the school requires. And some schools at the age of 3, nursery schools, may require no diapers, and that's a patient who might start enemas at age 2.5. Some families might not be sending their child to school until they're 5, so no worries until 5 years of age. Well, we employ the ACE in, first of all, a patient in whom we are pretty confident that they are going to need enemas, number 1. And number 2, in a patient who is starting to get annoyed by the rectal route and wants to gain a little bit more independence. So most of our Malones are being done somewhere between age 5 and age 12. We've certainly done them in older patients, teenagers, and even some young adults. And it's a wonderful, wonderful procedure. So we're getting speaking about adults, and I'll say young adults. This adult is 46, so that will make me feel young. If I say that 46 is young, many of you probably disagree and think 46 is old, but and the patient is telling me that they have watery stool, and they're taking cholestyramine, which is a medicine that helps bind the stool and make it more firm. And there are a number of questions about hypermotility. So let me handle that. Most patients deal with hypomotility, which is slow moving colon. But there's certainly patients out there with hypermotility, fast moving colon. Well, again, the strategy is to quiet down the colon and make the colon not do anything until the enema comes along, or for the enema strategy, or make the colon slow enough that it produces 1 or 2 well-formed stools a day that one can feel and get to the bathroom in time to have a bowel movement. So how do we do that? Well, diet, very key. Avoiding laxative-producing foods and promoting constipating foods. And there's a nice list for that as we discussed. Fiber, water-soluble fiber. Pectin, very good. You can find it in any supermarket. Citrusel, 100% water-soluble, very good. And there are a number of fibers that are added to that. The next line of attack would be to add Imodium, loperamide, which is a medicine. You may have known this medicine. It's an anti-diarrheal. That is an effective addition. We sometimes will add something called Lamodal, which is another anti-diarrheal. We'll sometimes then, on top of that, add cholestyramine. And there are even a number of other things on that list. So there are very few colons that we can't slow down with the employment of a hypermotility strategy. And in answer to your question that you're still having watery stool despite taking cholestyramine, I would say diet, fiber, Imodium. You have 3 more things you could add to your regimen, and you may not even need cholestyramine. As we wait for another question, here it is. Jessica from Maine, one of our most beautiful states, his son is 16, has been on Miralax pretty much since birth. We had him go the same time every day, and that has seemed to work well, but since this summer he has had very large bowel movements, startlingly large. Any thoughts? Well, I'm thinking that colon is not being adequately emptied. I am not a fan of Miralax. Miralax is a stool softener. Again, those patients do not need softening of their stool. What they need is something that provokes the stool to empty in a reliable way. And the only 2 medicines that we have that improve the peristalsis, which is the motion of the colon, is something with senna, and there are a number of versions of that, but senna is the active ingredient, and something called Dulcolax. And that is also effective in provoking stool. Anything else I would consider a stool softener, and Miralax, I don't use it because what it does is it makes the stool too mushy. Now, for someone with relatively mild constipation, Miralax may in fact be very effective. But in patients with more severe constipation, I think Miralax is not helpful. So in a patient like that, I would have to figure out how big or small is the colon. Contrast study is the way to go on that. And then we would probably put a patient like that on a different regimen, not Miralax, but rather a more provocative laxative, something containing senna. And I suspect that would get the colon to empty more regularly, and then the stool sizes would go down because basically every 24 hours the colon would empty. What I predict is happening here is the colon is accumulating stool, and when it gets to be a certain size, the stool, it empties, and it's quite enormous. We have patients that only stool once a week. That's bad. That's a patient that's going to be at risk of getting impacted. Before the next question pops up, I want to describe sort of this routine of how we do these x-rays throughout the week, because it's a very effective strategy. Our first step is we get a contrast enema. As I said, we want to know, what does the colon look like? How big, how small? Is it a fast colon or is it a slow colon? We can determine that from the contrast study. We don't really need manometry to tell us what we can tell from a very beautiful picture called a contrast study. We then want to make sure that the colon is clean, 100% clean, before we start any of our strategies, because many of the patients come to see us and their colons are impacted, full of stool, hard stool. And unfortunately, that has been the source of some of the failures in patient care before they've come to see us, where the doctor never ensured that the colon was empty before they started them on treatment. So for example, if you have a colon that's full of stool and you start a patient on laxatives, you're going to have a very crampy child and a child who's never going to want to take that laxative again. And then you declare that the laxative didn't work. Well, the truth is it would have worked fine had you started off with an empty colon. So we define the anatomy, we make sure the colon is clean. The nice thing about the contrast study is that not only does it show us the anatomy, but it also helps to clean the colon, because the fluid that's used for the contrast study is actually a very strong enema. So we get a clean colon. Then we determine the treatment. So there are two sides of that coin. One is the patient who's going to be on enemas, because we've determined that they need enemas to remain clean and we're not going to try to potty train them now. Or the patient that we think has good potential for bowel control but just needs a medical treatment, usually laxatives, sometimes treatment for a fast-moving colon. The goal being So we prescribe our regimen. So let's play out the enema routine. We give an enema based on the size of the colon. Again, saline, somewhere between 350 and 750 cc's. Glycerin, 10, 20, or 30 cc's. Soap, we like to use Castile soap, although a number of liquid soaps will work, 10, 20, or 30 cc's. And to make it even stronger, we might add phosphate, also known as fleet. The generic is phosphate. So we then have the family give that enema at night, and the enema routine is quite specific. It's given with an enema bag, through tubing connected to a Foley catheter, which has a balloon on the end. That's inserted into the rectum. The balloon is inflated so the enema fluid does not leak. Very important. If you give the enema fluid and it leaks, it basically didn't give an enema. So then it swishes around in there, sort of breaks up the stool. The child goes on the potty, and we hope has a effective enema. And then we determine how the patient did. So the next morning we get an x-ray, and the x-ray shows clean colon. Great. We give that same enema that night. If the x-ray shows a full colon, while the enema that we gave was ineffective, we need to make it more powerful for tonight. And on occasion, on occasion, the enema is too strong and actually provokes bowel movements, and that we learn because the x-ray is clean. meaning we clean the colon, yet the child is having accidents. And in certain circumstances, then we will actually make the enema less potent. Just scrolling down to see the next question. Then we continue that throughout the week, and we keep getting x-rays, and by the end of the week, we have a completely clean colon. And we have thank you. And we have talking for all this time makes me have a cough. Thank you. Okay, so the next question is, oh, by the way, sorry, let me just finish. So that would be the enema routine. In the patients who are undergoing the laxative routine, we give a dose of laxative, something containing senna. We guess at that dose based on the size of the colon and our interpretation of how fast or slow that colon will be. And then we give a dose of laxative. And the same way, we check with an x-ray the next day. And if the x-ray looks clean and the child has stooled, then that dose of laxative is going to be repeated that night. However, if the x-ray shows accumulated stool, then the dose that we chose last night is not enough. We need to clean the colon with an enema and increase the dose for that night. And we play that game for the week. And the final scenario is the child has 4 loose stools and the x-ray is clean. Well, the dose we gave last night was too much. We have to reduce the dose. And we play that out for a week, and at the end of the week we have a regimen that works. And of all those patients, and we've run nearly 1,000 patients through that routine, 95% of them are perfectly clean. Who are the ones in the 5%? The ones who cannot form solid stool, which luckily is extremely rare. So the patient that we throw all of those things at them and they still cannot form solid stool, those are the ones that are not going to be successful. And patients who don't comply, who don't follow our instructions. Here we have a mom of 4 girls asking, what is the difference between glycerin and Castile soap? And can you use one over the other? They both do the same thing. They're both provocative. They're both making the enema more potent. We usually start with glycerin. It's a little bit stronger. We add Castile soap. It's a little bit milder. You can use one or the other, and sometimes we use both. Depending saline and soap only, and we have plenty of patients on saline, glycerin plus soap. All right, Jennifer from Chicago writes that she has a 1-year-old, this is a question about Hirschsprung's disease, was treated for enterocolitis after a pull-through for Hirschsprung's disease with irrigations, Flagyl, Miralax, Botox. Stools are very loose. Should they be formed soon? Well, this is an interesting question. It's not that related to fecal incontinence because we're talking about a baby, but obviously it's a colorectal problem we deal with a lot. In this circumstance, you sort of want the stool to come out because enterocolitis in Hirschsprung's disease results from stagnation of stool, from stool not moving. And stool not moving through, sort of like a pond, allows bacteria to grow, and the bacteria can then cause diarrhea. Similar to the diarrhea that you might get if you contracted a food poisoning or a bacterial infection of the colon, you have loose stool related to that. So as the enterocolitis gets better and you are undergoing correct treatment with irrigations and Flagyl, I'm assuming the Miralax has been added to make the stools loose and make the irrigations easier, which makes some sense. And the Botox was given to make the bottom sphincter a little looser to get the stool out. Once the child recovers from the enterocolitis, then of course your goal is to get more formed stool, 1 to 3 in a baby, even 4 or 5 stools per day. And then you're back to sort of a normal routine. All right, so there's a number of people asking about what they can do at home and why is the week-long program necessary or recommended. Well, I mean, of course, there are many of these things you can do at home, and if you succeed, stay at home. There's no reason to come for a one-week program. And I can tell you that there are a couple of places around the country and the world that are trying very hard to establish this one-week similar program. A number of partners of ours around the world that are trying to do this because it's so effective. The issue is, I think, that if you have a patient with a problem like this and they see a doctor and the doctor prescribes some treatment and says, come back in a month, well, in a month you pretty much have the same patient returning. You really haven't improved things. We found that if you really force the regimen to find a regimen quickly and check that regimen every day for 5 days, you're welcome to try this interested, but we found that that got us a regimen quickly. We started meeting patients, and this was many years back when Dr. Pena came up with the idea of the Bowel Management Program over 20 years ago. We met many patients who suffered for many, many years, because they kept changing the regimen a little bit here, a little bit there, and never really nailed it. Whereas in 1 week, you sort of force the new regimen, you force the compliance, the family really concentrates on solving the problem, and in 1 week's time, they are successful. I remember a very nice story of an 8-year-old boy. His name was Joey, and on the first day, on the Friday, I said to him, I promise that in 1 week, you will be clean and in normal underwear. And he looked at me like many 8-year-old boys do, like I was crazy, and I couldn't possibly be correct about my promise. Well, 1 week later, after a successful routine had been worked out, he walks into the clinic very proudly and says, Dr. Levitt, you make good promises. And it really struck me that a lot of our kids, and I'm a parent myself, we are offering things to them. We are promising things to them a lot. That's sort of part of our relationship. And this was something he really wanted to achieve and really had not achieved. And so he felt that that was a real special gift that we gave him, that control and that independence and being 100% clean. And I can tell you that the 1 week program, what it does is it is much more likely to achieve success. I could take the exact same patient, see them once a month for a year, and never achieve what I can achieve in 1 week with a serial group of x-rays. So I'm not exactly sure what this question is. Someone's writing in that they had a patient had a repair done previously. I'm not sure what the question means. I'm sorry. How much laxative is too much? Someone's writing that. That's a very good question. How long do we need to be on it? How much dose is safe? I can tell you that laxative senna is the safest medicine that I know of. We've never had any problem. We have hundreds and hundreds of children on senna. And honestly, I do not understand why there is such a negative feeling about laxatives. It's true all over the world. Every country I've been in, the parents don't want the children on laxatives, and they're being advised by their doctors to not take laxatives. And I simply don't understand it. We need a medicine that provokes the colon to act. We don't need a medicine that softens the stool. And this is something that we often differ from our colleagues around the world and around the country. And I can tell you we are very active about giving patients this medicine, and it works, and we have not had a problem with it. And I will tell the story when a family shoots back at me, how long do we need to be on this medicine and why do we need to be on it? I say, if you had your child diagnosed with diabetes today and the doctor said you need to be on an insulin shot, I can assure you, you would not ask, how long do we need to be on insulin? Because diabetes and insulin sort of go together. Insulin is the medicine for diabetes. If you have high blood pressure, you take a medicine, the blood pressure goes down. If you have high cholesterol, you take a medicine, the cholesterol level goes down. If you have a slow-moving colon and you take laxatives, the colon gets better. Very simple. I would consider a laxative just like any medicine. The only difference is it's over the counter and it's exceedingly safe with no side effects that I have ever figured out. So I have no problem with it. So another question here is, what age do you recommend for bowel management program? And the answer is basically whenever the child needs to be in normal underwear. He's currently 21 months old, and we're not having success with Little Tummy's laxative. That's a version of Senna. I'm not sure what you mean by not having success, because at 21 months of age, to me, success is for a 21 months old colon, other than to avoid impaction and avoid constipation. When that child is of an age that you need him clean and in normal underwear and out of diapers, that's the situation where you need to think about a bowel management program. Because if they successfully potty train, great. If they don't, then you're faced with the circumstance of having a child in diapers when their friends are in normal underwear. And that is a social situation that we are trying very hard to have children avoid. So if he's 3 years old and all his buddies are in normal underwear and he's nowhere near potty training, bowel management is the way to go. So Larry writes, can someone over 30 gain benefit from the Malone procedure? Absolutely. We have done a number of Malones in older patients, and we have done a Malone in a 70-year-old. Well, we have to collaborate with our wonderful adult colorectal colleagues, and we have some great ones at the University of Cincinnati that we work with, and they are actually learning the Malone. They like it, and we're collaborating on those procedures in patients who are too old to be taken care of at a children's hospital. Just the other day, I operated on a 51-year-old wonderful patient who really benefited from a Malone. She had a spinal problem, and the adult colorectal surgeon, my friend and colleague from University of Cincinnati, Dr. Davis, came over, and together we operated on her. We took advantage of his skills at doing laparoscopy in a 50-year-old, which I used to do when I trained in general adult surgery, but now I'm a full-fledged pediatric surgeon, and took advantage of his skills taking care of the adult from the laparoscopy point of view. We took care of my skills in creating the Malone, and together we performed a very nice operation for this 51-year-old who is very much enjoying her Malone. I can tell you, in a lot of adults, they have very challenging regimens. They have lots of medicines, 6 or 7 different medicines, and they get a lot of gurgling in the abdomen and sort of unreliable passage of stool at unpredictable times, and it interferes with school or with work. They go to an enema program, and now they have a devoted 30 to 40 very reliable system, and I think that's one of the reasons why the Malone is so useful. So absolutely it can be done in adults. So Melanie in Pittsburgh writes, with the Malone procedure, can the belly button stoma leak? And is there a way to take a day off in between daily enemas? And so the answer is yes. The two problems with the Malone are that the hole can get narrow. That occurs about 1 in 10. And the stoma can leak. We have not had a leaking Malone in about 10 years because we've gotten very good at creating the valve. Only when the valve is not done well, or if the valve starts to loosen over time, which does happen in a very small percentage of patients, then that Malone might leak. And the treatment is to tighten the valve. It's not an enormous fix when it's not a hard fix when that happens. But most of the time we don't have leakage, but we definitely get about 1 in 10 have a narrowing, which is also a very minor fix to make the hole a little bit bigger. There are many patients that are successfully doing enema regimens every other day. It is absolutely not mandatory to do it daily. We sort of insist on doing it daily at the beginning to get a routine, but many patients, particularly Spina Bifida patients, have relatively slow-moving colons usually. Those are ones that are usually very capable of doing an every other day enema. See, I'm waiting for another question here. I will tell you a little bit more. The nursing collaboration is really key. So each patient who comes gets assigned a nurse, and there's a daily communication with that nurse to find out how the patient's enema or laxative regimen or whatever the routine was from last night, and how did the enema go, any details, what did the x-ray show, which we go over together. And then the nurse then communicates with the family again and changes the regimen for that night. And then we work through that rest of the week. I'm pretty useless, frankly, without my nursing colleagues, and I said that we have 9 of them that are quite expert in bowel management. And they are writing and they are lecturing around the world, and we have nurses from all over the world who are visiting with us trying to learn the routine. So if everyone could, I'm going to come close to our last question. We are this is a new venue for us to try to reach out to you. I wish you could perhaps type in link or a friend who got the link, or many of the other ways we've tried to find you to get you connected to this ClickCast. It would be very helpful to us if you could type in what it was that got you here tonight. Because when we do this again, which we will, and we will do this on a number of different topics of interest to you, we want to know how to get the message out the easiest way. So this is a great question. Renata writes that the question is, will doing enemas long term hurt her son's chance of having voluntary bowel movements? And the answer is no. In fact, I think they help, because the enemas get the child clean. The child learns what it's like to be clean. They are 100% clean. They are in normal underwear. They are happy. Then 6 months, a year, 2 years later, you say, hey, you want to try to get off those enemas? This is what we need to do. We need to potty train you. We need to sit on the toilet 3 times a day, have meals at reliable times, listen to your parents when they ask you, listen to your body when you feel a cramp, when you feel a fullness, go find the potty. All of those things are part of the behavioral training to get someone to potty train. I can tell you, if you have a kid who's clean in normal underwear, they want to stay that way. So their sphincter control is intact, independent of the enemas. I can assure you, as soon as those sphincters are called upon to work, they will start working again. So I really want to apologize to any of you whose questions came through but we didn't get to. We tried to get the questions we try to get to all of your questions, but understand that there are 200 plus people out there. We can answer your questions. We want to answer your questions, and I would recommend you email our center directly. You'll see an email address scrolling at the bottom of your screen, and we will get back to you. Our nurses are ready to roll tomorrow morning, our time, to reply to your questions, and we will reply to you within 24 hours with any questions that you have. And I feel bad if you didn't get your question answered, but we will answer them. Also, if you felt that you had a very patient-specific question that wasn't sort of a general question to the group, we will handle those individually as well. It's our pleasure. Our goal is here just to get the information out to you. Our challenge has always been how to find you, because we understand that there are a lot of children out there that are not fixed, and we feel we can fix them with the right level of communication and the right education. So please help us find those individuals. If they weren't able to connect to us online, we'll be aware of another ClickCast. The Facebook site is always available to post questions, and you're always welcome to email us directly. So with that, I'm going to sign off. Nice to be with all of you. I'm sorry that I couldn't look you all in the eye. And I hope this was a good venue and one that was educational and interactive, and we look forward to doing it again. Dylan's typing me something though.
Just don't delete. Don't delete the video.
I won't. So, all right. Well, good night. We're going to sign off. So you want me to hit?